Well, thanks so much for joining me today for episode 8 of season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. I want to again begin today by thanking the SCAN Group and the SCAN Health Plan for funding this podcast. SCAN Group is the parent company to the medical group where I work, Healthcare in Action, which focuses on caring for patients experiencing homelessness. So today is actually a bonus special episode of the Healthy Skeptic MD. With the surge that we unfortunately are seeing with COVID-19, there's been a lot of questions from viewers about where things are with children. So I'm going to bring back my wife, Pediatrician Dr. Jessica Hochman, who's been on several previous episodes and has gotten a lot of good feedback on those episodes to help us all break it down. Jessica does have her own YouTube channel, Ask Dr. Jessica, so check that out. You can also find her on social media. And if you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Look for the YouTube channel, pass it on to friends, family, and others who might be interested, and please do consider leaving a review. Because today is a special bonus episode, we're going to skip the news summary and jump right into our interview. Well, welcome and thanks so much for joining me today for a very special episode of the Healthy Skeptic MD with my wife and pediatrician, Dr. Jessica Hochman. She's been on the show 3 times already.
3 times.
And we've talked about COVID in kids and a couple other pediatric topics. But there's been obviously a big rise, unfortunately, recently in COVID-19 cases. And in particular, there's been a lot of alarming headlines about COVID in children. So I thought this would be a good time to bring Jessica in and hear her perspective, help us break it down and figure out what we should do to get back on the right track here. Could you begin by just telling us a little bit about where you practice pediatrics?
Absolutely. I am a general pediatrician. I've been a general pediatrician for 10 years now, and I work in the suburbs of Los Angeles in a small town called Oak Park, and I work at Oak Park Pediatrics is the title.
Yeah, and I'll just say my unbiased opinion, Jessica's patients really adore her. You know, I'm there on the other end on those late night mom calls, and she can be very, very reassuring. So really someone to trust.
It's only a little biased. Right? Just a little.
Little biased, but I do think I'm being objective there. Okay, so one of the saving graces of this pandemic is although it's been a very, very serious illness for particularly frail older adults, kids have done relatively well with this virus. So can you begin by just telling us, what are some of the statistics about COVID in children?
Absolutely. So it's always hard, I think, to conceptualize these numbers, but big picture in the United States, there's been documented over 4 million cases of positive COVID cases for children, and it's estimated that there's at least 3 times that number that we've had positives that we haven't picked up or kids haven't gone to get screened. So probably over 12 million cases. And we also have documented under 400 deaths for children, so around 400 total deaths. And over 80% of those deaths have been in kids that have had, quote unquote, severe comorbid conditions.
Okay, so those are some interesting numbers, but one thing that helps to put it in perspective, at least for me, is to compare COVID hospitalization rates to the flu. And let me begin by saying that in older adults, particularly prior to the vaccine, COVID is a much more severe illness than flu, much higher rates of hospitalization and death. Hopefully that will change as immunity develops and more people get the vaccine. But what about in kids who do so well with COVID? How does COVID compare, for example, to a typical flu season?
Okay, so first of all, the flu in children is not something that I take lightly. I've seen some kids get very ill with the flu, although most kids do very well. So I don't mean this perspective. When I say this comparison, I do take the flu very seriously. But it is something that we've learned to live with. So I think it's an interesting comparison in that way. And so Mike and I actually looked this up together last night. This is how we spend our free time together. But in 2018, the flu season for children, there were 35,000 hospitalizations. And for COVID overall, so in the last year and a half, we've had 49,000 hospitalizations. So they're actually, I think, pretty comparable. And if you think about in terms of the sheer number or the rate of hospitalization, it's much higher for the flu. So because we've had so many kids get COVID, we're seeing a high number where typically for the flu season, there's less of a total number of kids. And I think that's because the COVID virus is brand new, or the SARS-CoV-2 virus, it's brand new. So we're seeing it really go through children easily because no child has, they haven't been vaccinated yet, so they don't have pre-existing immunity. And so therefore we're seeing a lot of numbers, and the hospitalization rates to the flu are fairly comparable, I would say. Would you agree?
Yeah, certainly the data we looked at, it looked like COVID and the flu were fairly comparable in terms of kids' risk of getting hospitalized, which is reassuring. But there have been some alarming headlines recently, particularly in some of the southern hospitals. There have been pediatric ICUs that are getting overrun. So has something changed? Is this new Delta variant, is it more severe in children?
So in some ways, I think, it's clearly harder on children just because Delta, as everybody knows, it is much more contagious. So just by sheer number, we are getting a lot more children infected with SARS-CoV-2. But it is not clear. In fact, I'm not seeing the data support that it's more severe. So we're seeing a higher number of kids in the hospital, but that's just because we have a lot more kids infected.
Okay, so
the data they're still waiting. I've seen some studies say maybe it's less severe, some studies say it's more severe. To me, when you look at the hospitalization rates, at the peak last January, it was something like 0.3 kids per 100,000 were in the hospital, and now it's 0.38 kids per 100,000 infected in the hospital. So, the headlines will say this is up. Hospitalization rates are up 25%, but still in the big picture, 0.38 out of 100,000 is a relatively low number.
Yeah.
And
I think it is very important to watch pediatric beds. We certainly do not want to get into a situation where there aren't enough beds.
Right.
But I will say that during a typical flu season, both adult and pediatric beds are very busy in hospitals. Hospitals are very busy places during January, February respiratory virus season.
Sure.
And by the objective numbers, again, we always have to keep a close eye on it. I haven't seen anything yet recently that makes me alarmed that we're going to be totally overrun.
That's right. I mean, I think what was alarming, there were some hospitals in Texas and Georgia, Florida, where the hospitals were getting higher numbers of children in the hospitals, and there was concern for, would we have capacity to take these children? But the good news on that front, as alarming as that is, it looks like the numbers have peaked in those areas. So in Florida, the case numbers have been pretty steady for the last week. So hopefully it's hit the peak and then will decline. But I think where we're seeing, this made a case for the vaccine, because the cities that were hit the hardest, where we saw the kids in the hospital at the highest numbers, were also the cities where they had the lowest vaccination rates. So, because Delta is so contagious, it really ran through those cities, and just by sheer number, more kids were in the hospital. I also think, because it's so hot, and we know that Delta spreads much easier indoors when it's really hot in Texas, Florida, the southern eastern states, people tend to be indoors. So when you have a combination of an unvaccinated population and being indoors, it makes sense to see that the COVID numbers are increasing.
Yep, that makes sense. Okay, I want to shift to schools.
Okay.
Schools have been starting to reopen this fall season, including our kids are now back in school. And there's been a lot of different policies in place.
Right?
Thank goodness.
After a year and a half.
That's where they are now, and why we're able to do this podcast together. But there's been a lot of different protocols and policies in place. Masks, social distancing, testing. What have you seen in your patients in terms of what the schools are doing?
There's a lot of variation. So where I work in Ventura County, they're doing what's called a modified quarantine, procedure. So if somebody gets exposed, the kids that they're exposed to don't necessarily have to go home, but they have to test and mask. And there's procedures there. And then LAUSD, where our kids go to school.
And that, of course, is LA Unified School District, which is the second largest public school district in the country.
Yes, I know for our school district, they do weekly testing. I'm not actually sure what the quarantine procedure is, but I've just heard across the board, a lot of schools are doing it differently.
Yeah, so LA Unified, they've been really very proud of the fact that they've had one of the more intensive COVID protocols in the country. One of the few that they're actually doing weekly testing of every child in the district. So our kids have been going through that. Can you just say a little bit about how that testing protocol has been going?
Sure. I mean, I can tell you our personal experience. So this is something Mike and I talk a lot about because It's interesting. I think with testing, it sounds like a really good thing to do. The idea, okay, you test kids and hopefully you'll catch a lot of the positives and keep schools a healthier, COVID-free environment. But I think there's just a lot of holes with this plan. So firstly, it's really expensive. The LA Times said it's $350 million to test 500,000 staff and students a week. So it's a tremendous endeavor. And then I think what was disappointing was we read that 1 in 5 kids did not get tested. This is the week before school started, so they were not allowed to go to school. So that's obviously not
20% of kids missed the first day or two because they just hadn't gotten that test completed.
Hopefully that will change, if they do testing in schools.
And they're going to start testing in school, but the pre-school test.
But I think I just wonder if it really works, to be honest. Again, I think it sounds like a great idea, but I think about, if you test kids on a Monday, there's a whole week that goes by where they could get exposed and still go to school. So, they could get tested on a Monday, be exposed on a Tuesday, and nobody would be aware. I also think if you test a kid on a Monday and they're positive and you don't get the results till 2 days later, there's potential for spread in the school or exposure in the school. So I think what would work better in a perfect world is if you could test a kid at the point when they walk into school and get immediate results. That'd be nice. But
yeah. So, I've looked for good data on the value of testing and
What'd you find?
The first thing I found is that there aren't and there never will be great studies that are going to be able to rigorously assess the impact of, for example, a weekly testing protocol. But there are mathematical models. And what those models show is that for it to really have a significant impact, you need to do it on an every couple day basis, and you need to be able to act on that result right away. So if you send the test and it comes back a day or two later, which is what many cases happens, that's too late. I mean, you sort of miss the boat. And again, weekly testing, you catch one cross section in time.
Right.
And there were some estimates that, weekly testing protocols with a turnaround time of 1 to 2 days. I mean, not that there's no benefit to it, but that it probably only reduces the risk of spread by 20% in school.
And then, of course, there's the false positive possibility. So we know that that happens. Some kids do test positive where they're not actually infected. And then I also think I always ask.
Do you know how many kids tested positive in LA Unified?
Tell me.
According to the LA Times, it was over 3,000 kids tested positive in that first screen, and then another 3,000 needed to be quarantined. So there were 6,000 kids in that first week who weren't able to make it.
It's a lot of kids.
But I'm sorry, you were starting to say.
No, I mean, I ask myself, what next, right? So a kid tests positive. Let's say that positive kid went to school. How catastrophic would that really be? So we know that kids are largely either asymptomatic. So we see it with the kids that were tested positive at LAUSD, they were tested without symptoms. So a lot of them are asymptomatic. And then the question is, how good of spreaders are children? And that's unclear. I know I have some colleagues that are concerned with asymptomatic spread. To me, the data isn't convincing that it's that large of a contributor to spread of disease. So maybe there is some spreading that happens, but does it actually increase hospitalization rates? I mean, this is what we really care about, right? If kids are just getting asymptomatic, they're not getting symptoms, or their symptoms are a mild cold, to me, that's not a public health crisis. But if they're leading to increased hospitalizations, that's where my concern would be heightened.
Well, the big unanswered question for me is, are they going to bring it home and infect a grandparent?
Right.
My concern about that, though, is less now that the vaccine is widely available and older adults who have been interested and have been able to get that vaccine.
Right. And I think that's where the fear, to me, has outpaced the reality of the situation. I think that, if kids do bring it home and they've all had an opportunity to vaccinate loved ones, and those that are at greater risk, I think the fear should be truly lessened, because if, no one wants to get sick, I don't take flu symptoms lightly, but if it's going to keep people from getting really sick, well, that's really noteworthy, because, gosh, to keep kids home for 10 days or siblings home for 10 days, closed classrooms, there's a lot of that's not something to be taken lightly.
Yeah, and the one other real world thing that has happened, and we've seen it with our friends and their kids.
Yes.
When someone tests positive or is home for quarantine, a lot of times it's the grandparents who are picking up the slack and doing the babysitting, who are probably the last people that you want to be around.
Absolutely.
Someone. So
no, and last minute childcare is really a challenge. I mean, I think it's very hard for parents at the last minute to find care for 10 days.
It may seem like we're picking on the testing policy, but
I mean, I would support it 100% if it seemed to be a good thing to do, but I worry that the trouble of getting it done, the cost associated, the little, at the expense of little benefit, if at all, I just think it's something that we should think about.
And that was actually the last point I was going to make about it, is in terms of cost. You mentioned that it was $350 million for the first semester to do the testing in LA Unified School District. LA Unified is not a wealthy district. The dollars per pupil is a lot lower than it is in other parts of the country.
Right.
In fact, our school, the parents have to fundraise to pay for a gym teacher because there's such a shortage of funds. We also this year got asked to make all the parents got asked to make an $800 contribution to the school instead of the typical $500. And a big part of the justification was that increased COVID costs.
Right.
So,
and the irony too is, I would say that there's, having PE at every school is potentially more protective against COVID outcomes than doing weekly testing. I mean, we know that kids staying healthy will keep them, or Americans staying healthy, fit is a big protector against severe COVID outcomes.
So I think we really do have to ask the question, is that $350 million that we spend on weekly testing, could it be better used for things that would actually have more educational and health benefits for our kids?
Now, my opinion on testing is not to say I don't really think schools should work on what we call mitigation factors, doing things that we know help decrease COVID spread. So, I think there's a lot of value in making sure that schools have really good ventilation, that kids, eat outdoors when possible, that they're outdoors when possible, that they try to keep a little distance. And I think masking indoors when there is high community spread is of value.
So let's talk about masks, because that has been a politically charged issue.
Are you sure you want to go there?
Well, what I was actually going to say is I actually would like to take politics out of it and really just talk about it pragmatically and from the science. And the first question I want to ask for you is, what evidence is there about the benefits of masks in kids?
Yes.
And then there's also been the downsides, that they're uncomfortable, that they lead to social interaction challenges. What evidence that those are legitimate concerns, or is that just nonsense that people are bringing up?
I think with masking, what's tricky is it's going to be hard to find really good evidence. My feeling on it is if there's some layer of protection that's provided, it's worth to do if there's high community spread. So there was that hair cutter example. It was actually brought up again in the New England Journal this week about those two hair cutters that were positive. They were cutting hair of, I think, 160 something clients. Both the hairstylists were positive. They wore masks and all of their clients wore masks. And when they followed up on all of the clients, none of them were positive for COVID. So there is definitely evidence that bilateral mask wearing may decrease.
Bilateral meaning both people.
Both parties, yes.
Yep.
So I think, when there's spread and there's COVID in the area, I think that makes some sense. But I have to say, I find very little evidence that, actually for children, I haven't read any studies that it's prevented spread amongst children. So I think the assumption, but it doesn't bother me for kids to wear masks because I think there's potential for benefit if there's high spread. But I have to say that I don't want it to be there forever. I think that there has to come a point where, the COVID in the community is maybe after Delta's waned or things have come down, where I do think it's important to have our eyes on the prize that the masks come off, especially, I want kids to see, like our daughter, for example, told me it was really hard to follow the teacher clearly this week because the teacher was wearing a mask and she couldn't see his face. And just, it makes sense. I want kids to see other kids' faces. I think, it's nice to see faces, to see reactions, expressions. They're uncomfortable. So what do you think?
And the discomfort, for a kindergartner or a second grader, that can be a big deal if they're not paying attention in school because they are uncomfortable. My view on this is it's going to be really hard to do a rigorous study to demonstrate the benefits of masks. We need to use common sense here. And it certainly seems from the evidence that we have, the hair stylist experiments, some of the epidemiologic data comparing regions that have used masks with those who don't, that there is some benefit from the masks. They're not perfect, but there's a benefit from them. So to me, when rates are high, using them in indoor settings makes a lot of sense.
Right.
But I think, as you said, in outdoors, the benefits probably are not worth those annoying downsides. And when rates in a community are low, at some point in the future, we should be able to relax standards and hopefully move past masks at some point.
Absolutely. And in terms of outdoor masking, that's one area where I do feel like it'd be better for kids not to have to wear masks, optional, of course. But we know that the virus dissipates really well in the air. And I feel that let the kids, wear them in the classroom setting, but sort of have a mask break outdoors where we know the spread is very low. I think there was an Italian study that showed you're 18 times greater risk of spreading COVID indoors than outdoors with mask wearing. And I actually have yet to find a true study that shows an outbreak amongst kids in the outdoor setting. I think they've shown some sports teams that have had spread, but all those sport teams, if you follow them, they do spend time indoors together as well.
And I will say, this is anecdotal. I would have agreed 150% with what you said a week ago, but I have heard anecdotally with Delta of a couple cases of outdoor spread becoming more common because it does seem
more
to
contagious.
be. So we'll have to follow that. There was something that Michael Osterholm, the expert at Minnesota, was documenting. So I think that's something to follow. But I think certainly for now, the evidence we have is that you're very safe outdoors.
I mean, to me, the big picture is just knowing I don't know everything, right? And you don't know everything. We all don't know everything. So it's weighing the benefits and the risks. So if it's possible that something a low intervention may potentially be helpful for decreasing spread, I think that's worth it. But I think it's good also to follow, the more that we learn about this, maybe comparing what some schools are doing, what other schools are doing. So, for example, if one school isn't using masks and it seems like they're doing okay, I think it's important to keep an open mind. What do you think?
I think that's one of the keys, that we need to be willing to respect different viewpoints, to objectively compare different experiences and make the decision that's right for your community, and try not to overly judge people who make decisions that don't align with yours.
I couldn't be said better. I agree with that very much. Because I think, it's like telling our kids what to do. It seems like a good idea. You tell people what to do and you hope that they'll just do it because you say it. But I find it's much more fruitful and helpful if you, educate people, explain things to people in a nice tone, nice discussion, then you hope that they make the choice on their own.
Yeah, well, that's certainly something as a primary care doctor we face all the time, even with things like benign things like screening for mammograms. Sometimes if you're too heavy-handed with those, you have to get that mammogram. Right. It actually can backfire. So there is an art.
They dig their heels more, right?
They dig their heels in, and it's an art form, that communication.
It's tricky. I don't envy the public policy. Those that have to make policymakers. I don't envy their job.
No, it is no one's going to be happy with them.
No.
So I want to end with an easy topic.
Okay, good.
Vaccines. So vaccines are now authorized, not FDA approved, but authorized for kids 12 and above. They're FDA approved for adults. Where are things in terms of kids under 12?
Okay, so just to nitpick a little bit, they are actually FDA approved for 16 and over for the Pfizer vaccine.
I stand corrected.
All right, so Pfizer is furthest along. They're doing studies looking at what's going to come out first is the 5 to 11-year-old approval, hopefully. And at first the data was supposed to come out in September, and it's going to take a little bit longer than that, hopefully before the end of the year, because they wanted a larger sample size. So I think that's prudent. I think that's a good idea. And what I like is they're actually using a third of the dose that adults have been getting. So adults are getting 30 micrograms per dose for the vaccine, and they're looking at 10 micrograms per dose for the 5 to 11-year-old age group. So hopefully what we'll find is that a good effectiveness with a very low side effect profile.
So I know this is a very rare side effect, but I can't help because it's made some headlines. What about the myocarditis concern in kids?
All right. So myocarditis is a very, potentially.
And what is myocarditis?
Yeah. So myocarditis is inflammation of the heart. Kids will show that symptom of, they'll have chest pain. They'll actually show elevation of something called troponin on lab work. It can be potentially very serious, but luckily what we've seen with kids is that most of the cases have resolved. It's actually very rare. It's about 1 in 20,000 kids. Specifically, we see it more in teenage boys and often with the second dose. And we were actually talking to our cousin's husband, who is a pediatric cardiologist, and he was saying that he's seen this at the hospital he works at and that it is real, but it is very rare, and usually kids overcome it.
Okay, so when the vaccine...
But one last thing I'll point out, I think the biggest point here is that when you actually do get COVID, you have a greater risk of myocarditis than getting myocarditis from the vaccination.
That's a very, very important point.
I just wanted to acknowledge there is that potential side effect.
Yeah.
Very rare.
And that actually gets to the last question. There are risks and benefits from everything we do in medicine. And when this vaccine hopefully gets authorized in younger children soon, it's not going to have the decades of experience that we do have with many other kids' vaccines. I'm hopeful it's going to be very favorable results and very favorable safety profiles, but there is going to be some uncertainty. So how do you as a parent, and we'll have to make the same decision for our kids, weigh those benefits and uncertain side effects?
I think that's the $1 million question. What I'd like to see is the vaccine become available for those that want to give it. The parents I would most strongly encourage would be kids that are, that have pre-existing conditions, that are more medically fragile. I think those kids would be first on my list. I understand parents that would say to me, if their kids already had COVID, is that enough protection? And I would say, they're right that when you've actually had COVID, that there is immunity from having natural infection. And maybe that would be something to think about, maybe just getting a booster or one dose. We'll see what, the FDA or the CDC recommends. But definitely on my priority list would be kids that are, that have coexisting conditions or they have other medical issues. And I also would think about who's in the life of the child. So if they live with somebody that's medically fragile, or they live with somebody that's had a transplant recently, they would also be very high on my list to get the vaccine right away.
So I actually don't even know what your answer is going to be on this one. What about our kids? How are we going to weigh that decision?
I think I would honestly, I think I would lean towards getting it, but I would like to see the data. We've had, our 3 kids have had COVID, so they do have some natural immunity. But if it looks safe, I'm all for them getting a booster. I think the more protection, the better. Good.
I'm glad to hear we're on the same page
really
with that.
Good.
But the one thing I will say is I do think it is important to respect all viewpoints, and I think that some parents may reasonably and understandably be anxious about the side effects.
Yep.
And given how good the outcomes are with COVID, I think we need to be patient and respectful of different viewpoints here. And
especially with the kids, I totally agree with you.
Yeah, and there may be a time in the future where a mandate like MMR vaccine and all the other childhood vaccines makes sense, but maybe that doesn't need to be in day one. And I think, as you always say, vaccines evolve over time.
Right. I always think about the history of vaccinations.
Yeah.
And there's a few on our current schedule that what we use now isn't the original formulation. So, for example, polio, we use inactivated polio. I think it started inactivated, then we used the oral version. Now we're back to the inactivated. The rotavirus vaccine that we use isn't the same version that we originally used. The DTaP vaccine, or the pertussis vaccination, is now acellular. It used to be in the whole cell form. Not to say I'm not, I think vaccines are a miracle. Don't get me wrong. I am such a fan of vaccines. I was the first one out there to get that COVID vaccine as soon as I could. But I just think it's important to keep an open mind that it's possible that the next formulation that comes out isn't going to be the perfect one.
And that's the way it should be.
Right.
Every vaccine is going to get better.
I just like the idea of keeping an open mind. Yeah.
Well, that's probably a good place to end. Thank you, Dr. Jessica Hochman, for joining me today. If you did find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Consider leaving a review if you have a chance. Pass it on to friends, family, and others who might be interested. And we'll pick it up again in a couple of weeks. Thanks for joining.
Thank you for having me.